This skill is direct orotracheal intubation of an adult. So first off, BSI, scene safety. I'm going to come up to my patient. I'm going to check for responsiveness using a sternal rub. Sir, can you hear me? I'm going to assess the pulse and breathing at the same time for no longer than 10 seconds on the pulse. So I can see that he has a pulse, but he does need supplemental oxygen and a supplemental airway device. So I'm going to start the skill off by using a airway adjunct. I'm going to measure the airway adjunct from the corner of the mouth to the tip of the earlobe to measure for appropriate size. So I'm going to use a scissor technique to open up the patient's mouth, placing the OPA at 90 degrees and inserting the airway. I'm going to use a base BVM for supplemental oxygen, delivering one breath every 5 to 6 seconds. Now I'm going to hook up my end tidal to see their capnographic waveform, and I'm going to also hook up oxygen to my cylinder for 100% oxygen to pre-oxygenate my patient before intubation. So while I am delivering one breath every 5 to 6 seconds, I'm going to get my equipment ready. So I can see that I have my device to secure the ET tube in place. I have the appropriate size ET tube along with the syringe with 10 milliliters of air to secure the device. I have my laryngoscope blade and my handle, and I have my stethoscope to auscultate bilaterally over at the epigastric. So after 3 to 5 minutes of pre-oxygenating my patient, I'm going to remove the BVM, still with the capnography on it. I'm going to open up the airway again using scissor technique, removing the OPA. Now I'm going to get my ET tube with jelly on it, so that way it's sliding down the airway. Lubrication, I'm going to sweep the mouth after I place the patient's head in a neutral line position. I'm going to sweep the tongue with the laryngoscope blade, making sure I do not depress the teeth and cause a fracture. I'm going to lift forward. Now I'm going to visualize the ET tube going through the vocal cords. Okay, now I'm going to remove my laryngoscope blade. I'm going to place my patient back on oxygen, deliver breath. Okay, now I'm going to note the depth. I'm going to insert 10 milliliters of air to secure the airway. Give a breath again, one breath every 5 to 6 seconds. Now I'm going to note the depth, just making sure before I go any further. I'm going to have my partner, maybe, use the BVM to secure or to hold the ET tube so that way it does not move. So I'm going to deliver another breath. I'm going to auscultate over the epigastrium bilaterally. So my partner's using the BVM. Looking and listening for equal bilateral chest wall movement in at least 2 places of the chest. Alrighty, so I've listened. I did not hear any noise in the epigastrium, so that does tell me that I have intubated the patient's trachea, so it is correct. So now I'm going to, with my partner's help, hopefully I'm going to place the device to secure the patient's end tidal tube, the ET tube, still delivering one breath every 5 to 6 seconds. I'm going to place this on, okay, make sure that it's on, one breath, okay, I'm going to tighten it, get that on there, cinch that down, one breath, place it on there, deliver a breath. I'm going to tighten the tube down, make sure that it's secure and does not move. So I noted the depth of it, it was 27. The main reason I'm doing that is to ensure that the tube does not dislodge from the trachea and pass back through the vocal cords. And I'm going to continue to use my capnography to also tell me if I'm actually intubating the patient and it's in the lungs rather than in the epigastric space and just causing distension in the stomach. So I'm going to continue to give my patients supplemental oxygen along with 100% oxygen as well until I see any response positively or negatively to the patient's outcome. And then I will continue to transport, continue to auscultate over the lung fields, and then just treat the patient as required.